Good afternoon, everyone. I got a signal from Poland headquarters that we can start together and start our today Endo Coffee. I got my own favorite coffee for the afternoon is cappuccino. You can write down in your comments which coffee is the best for your afternoon. In the morning I prefer Americano and double espresso, but at afternoon something more light and cappuccino is the best for me afternoon. I'm glad to see you, see in these difficult lockdown times. All world now is almost completely closed, maybe except Sweden. I don't know from which country you are watching me, but I am broadcasting from Poland. There are some nice and interesting cases today with you, and we can start. I think it's 3 p.m. Polish local time. At the beginning, I want to say some special greetings to one doctor from Kosovo that was afraid that he missed my webinar. His name is Edmund Dragusza. So special greetings to you. And I think you can also write down in comments underneath from which country you are watching me, and if we had an opportunity to meet before this lockdown, maybe 1, 2, 3 years ago, if I was in your country and you enter to my lecture on hands-on course, please give me the information that we met together. So, Edmund Dragusza, cheers for you with this afternoon coffee. And we will start with the presentation. Give me a second. So, at the beginning, few words about me. I finished medical university in Łódź in Poland. That's the third biggest city in Poland. The population is around 70 people there. After I graduated, I stayed there to finish my master degree in endodontics and conservative dentistry, and also I did a PhD dissertation from endodontic department of the university. I am a member of the Polish Endodontic Society, which is a member of the European Society of Endodontics, and also I am a member of the Polish Dental Ergonomics Society. So mostly I'm doing root canal treatment under the microscope every single day. I finished this medical university and I lived in that city, the Łódź city, for 15 years. This is the picture of the city, the beautiful one that completely, for me, looks like a Death Star from Star Wars. This is the drone captured picture in the winter time when the roofs are completely white and there's also some lights on the street give us the looking like Death Star. But 5 or 4 years ago I come back to my hometown and I'm running here my dental office called Endodental, and also I'm running my blog about endodontics, perfendoblogspot.com. My hometown is also located in the central part of Poland. It is called Wieluń. It's a small, maybe 26,000 people lives in this town, and I'm very happy to have more quiet style of life in this small town. Today, I want to present you some two interesting cases and also give you some more details about working in hard conditions when the canals are narrow and curved. And the first question that we should ask at the beginning is how flexibility of files improves the shaping protocols. The answer, it's easy in English, it's only 4 letters. They improve a lot. So flexibility is extremely important, especially when we have to deal with some curved and narrow canals. More flexible file it is less risk of doing some mistake during the shaping protocol. I'll share you some the first case. It's the upper first or second molar, I think second molar, on the left side. We can see that both canals, the mesiobuccal and distobuccal canal, are merged together and curved in the distobuccal direction. So I knew watching on this pre-operative X-ray that this case might be difficult. So I choose crown down technique because for me, when the canals are narrow and curved, crown down technique is one of the safest to shape and finish successfully the shaping protocol of curved canals. That time I treat this patient. I did this with Endostar E3, the classic one, because Azure version of the files from Endostar were not available yet. So this is the post-operative X-ray with both canal. You can see mesiobuccal and distobuccal canal are extremely curved. This is the second angulation of an X-ray. But look on this picture from a little more details, especially with this area of this canal. You can see here ledge that I was starting to cut on the external curvature of the canal. Luckily for me and for the patient, of course, I realized that I'm creating a ledge with the rotary file. So I stopped working with rotary files, pre-bent stainless steel manual files, and smooth this ledge on the external curvature. And because of this, I was able to finish the preparation. But last 2 or 3 millimeters of the canal were prepared by me manually. Normally, it's very difficult to bypass the ledge and finish the preparation with classic night-eye alloy rotary files. They are springing, they want to go back to the primary shape. That's why every rotary file with the classic night-eye alloy will create a ledge again. So that time I was able just to bypass it, smooth with the manual files, not the rotary files. Nowadays, when we had Endostar E3 Azure, that they are heat-treated night-eye alloy, we can pre-bend the rotary file and it stays pre-bended. So it's much more easy for cases like this to bypass the ledge, smooth it and finish the preparation with the rotary file, but with modified night-eye alloy. Nowadays, when I see case like this, when I'm sure that it won't be the normal one, the easy one, and I know that I will need to be more concerned about the approach of the canal, I'm choosing the E3 Azure Small and the crown down technique of working of them to and I'm able to shape even more extremely curved canals, and I will show you some interesting cases of this. This E3 Azure Small, it's additional pack of E3 Azure files. It consists of three files. Each of them in cross section are S files. First, with two yellow stripes, is apical size is 20 and the taper is 6%. Then the three red stripes, apical size is 25 and the taper is 4. And the last one, the smallest one, the most flexible one, is apical size is 20 and taper 4. And they are designed to work crown down technique. Of course, you can work with them not only in this crown down, but for me it's the favorite technique to use them. And nowadays I'm using only them in extremely curved canals. Previously, when E3 Azure were not available, sometimes I was switching some different rotary file systems in difficult cases, but nowadays these three files allows me to get the shaping protocol up to the end, even in extremely curved canal. How step by step we can work with these three files. Sorry. You can see the tooth, and normally when you don't have much experience with the system, it is good to start with the E3 Azure basic set. The file with one blue stripe is the orifice opener. It should work in the coronal half of the canal and open the orifice, create some straight line access. After that, we can measure the full working length, create some glide path, and normally, if the canal is not extremely curved or narrow, we can continue the shaping protocols with E3 Azure Basic. But in a narrow and curved canal, we will incur some problems. File number 2 and file number 3 will stuck in some part of the canal, and even if we clean the instrument from dentine debris, flush the canal with some irrigant, we'll still won't be able to get deeper inside the canal with these files. That means this is the information for us as a clinicians, that the size of the file number 2, 25 taper 6, is too big to finish the preparation protocol in this particular case. And this is information for us. Switch E3 Azure Basic into E3 Azure Small. When you gain some experience with these files in the rotary system, I think you will recognize after pre-operative X-ray that this case should be done with the E3 Azure Small and start from that point of the preparation. First of all, size 20 taper 6, so we get small apical size but big taper. It is our micro opener for the canal, and we work it with this file few millimeters inside the canal, I think around half of the full working length. Then we switch into the bigger apical size but lower taper, 25 taper 4. This file will be more flexible and will go some millimeters deeper inside the canal. And then the first rotary file that reached the full working length is the smallest one, size 20 taper 4, and that file is the first one that reached the full working length. Sometimes we need to give it few attempts. We need to have few attempts to get to the full working length. I mean, after second file, this smallest one goes, I don't know, 1 or 2 millimeters inside and stuck in inside the canal. Then we need to clean it, flush the canal, flush out any debris, and then continue our preparation with the same smallest file. If we created some glide path to size 15 before we use the rotary files, we will finally get the full working length with size 20 taper 4. So after this, our canal in the apical area is prepared up to size 20 taper 4, it's not too much. It's not enough to finish the shaping protocol. So at that time, at that point, we can go back to the previous file, 25 taper 4, and this time, when the smallest file creates some space in the apical area, this size 25 taper 4 will have more space and more opportunities to get to the full working length. So we can go back to this file, but this time insert it at the full working length, and then we can decide if this 25 taper 4 gets to the full working length quite easy, without any resistance, without any problems. We can go back to the smallest file from E3 Azure Basic. It is size 30 taper 4, and also enlarge the apical part of the canal and finish the preparation size 30 taper 4. It depends on the curvature of the canal. Extremely, 90 degrees, extremely curved canal, I will prefer to finish 25 taper 4. But if it's not, if the curvature is not so abrupt, we can consider to enlarge this to size 30 taper 4. So please look at this first interesting case. I take a post-operative X-ray here. The post-operative X-ray because I was treating the tooth number 17, so upper second molar, and this is the post-op, direct post-op. We can see that there's no tooth number 16. It was extracted when this patient was young. And there's something very interesting when you look at tooth number 15. We see that it's in malalignment. The root is malalignment. It's not staying straight. Also, we get some very strange metal pin going from inside the pulp chamber to the bone. At that time, the tooth was completely asymptomatic. So I said to the patient, it looks strange. There was no tenderness on percussion. There was no problem with the probing, and the sulcus was normal. So I told the patient, let it be like it is, because when you will have some problems in the future, we will have a problem to treat it, because I can remove this pin. I will try to close the perforation after that pin. I will do the retreatment, but how can we restore such a severely destroyed tooth and crown structure? It is almost impossible to place some metal or fiber post and place it on the top of it very tight crown. So I told to the patient, let it be like it is, and we will see in the future if there will be some problems. And unfortunately, after I think 6 or 7 months, she came back with the huge pain. This tooth 15 was tender to percussion. There was a swelling around this area. So we decided to remove this tooth. And the patient had two options. One is placing some implant. One is doing some fixed bridge. And she chose the fixed bridge option. But before I wanted to fix the bridge, I told her that we need to do retreatment of the first molar, as it should be a good pontic under the bridge. This is the beautiful pictures of that strange pin in this area. You can also see a leakage between, let's say, composite crown restoration and the root structure. And look again, but in some closing to this first premolar. We can see one canal is obturated up to the end. Let's say it's also a homogenic obturation. The second canal is underfilled. It's the obturation material ends not in the apical area. You can see this with that white arrow. But what else can we see here? this is something strange with the periodontium, because periodontium is here. It means these two canals are oriented in the central and left part of the tooth. The right part of the tooth is empty. And normally it might be some information to us that there is something wrong with the anatomy. It is more complex than the typical first premolar, and we should suspect something strange like third or even fourth canal in this premolar. And that was true. I located the additional canal. The mesiobuccal canal was completely missed during the previous treatment, and I do this retreatment. You can see here on this pictures from microscope. On the left side we can see both buccal canals, and they had a common orifice, and after 2 or 3 millimeters underneath the pulp chamber floor, they are dividing into 2 separate canals. The distance between these canals is very narrow, it's less than 1 millimeter. And then you can see that after the shaping protocol, I placed master cones with some adsil, I think it was. And then the last on the right picture, you can see the situation after the obturation. I used continuous wave of obturation, and I shaped the canal with Endostar E3 Azure Small in crown down motion. Both buccal canals, because they were narrow and curved, were prepared, as you can see, to size 25 taper 4, and the palatal canal was enlarged to size 30 taper 4 because it is the biggest canal on this tooth. And this is the post-operative X-ray. On the left side is direct post-op with some rubber dam still on the tooth. On the right side is without the rubber dam in different angulation. After I placed the fiber post and rebuilt the core of the crown. So that was the first interesting case. After that, the tooth were prepared and impressions were taken, and then we prepared porcelain fixed to metal bridge in this area. And the second and last interesting case today on this Endo afternoon coffee. This is the picture, the panoramic picture that this patient bring to my office. Of course, everyone looks right now on the tooth number 38 and 37, but unfortunately it's not a job and work for endodontists. This is just for the surgeon. The tooth number 37 was totally destroyed by pressure of the tooth number 38, so both of them should be extracted. The patient comes to my office to save him tooth number 17, and you can see on this picture that there is a huge bone loss from both sides of the tooth, and also some metal standard post that it is on the visible on this X-ray, but this picture was not up to date. The patient has with him some X-ray film, and this is the picture of this X-ray film I took with my phone. You can see the previous dentist removed this metal post, but when we analyzed this X-ray film with the patient, I told him that for 99% there is a root fracture. That's why the bone loss is so huge. It was like 8 or 9 millimeters deep among the palatal root. So I told the patient it is not a good idea to save this senseless case, and I advised him to extract the tooth, but I also told him and show him on this X-ray that the first molar has also had a huge problem. Look at the size of these periapical lesions here. We got periapical lesions surrounding the mesiobuccal root, distobuccal root, and palatal root as well. So I told the patient, extract the tooth number 17. I can help you with the tooth number 16. and then you can do, for example, a bridge here or whatever you want. It might be doable. And that was very interesting case according to the anatomy, because in this first upper molar I found six canals. This is 3 pictures from under the microscope that you can count canals with me. Now we got mesiobuccal 3, mesiobuccal 2 and mesiobuccal 1, distobuccal and 2 palatal canals, mesiopalatal and distopalatal. And you can see that the beauty of the internal anatomy of the tooth. And I started to deobturate the canals with Endostar re-endo system. Then I measured the full working length. Then I go with the Endostar E3 files and finish the shaping protocol. On the picture on the right side, you got clean pulp chamber floor after final irrigation. And I got a question from you. Do you use any kind of lubricant during treatment of curved root canals? It depends. If I'm able to penetrate the canal with file number 10 without any lubricant and establish the full working length, I'm not using a lubricant. But sometimes the canal is so narrow that even after coronal pre-flaring, after primary opening the canal space, I'm not able to reach the full working length with file number 10, and I need to switch to the smaller size number 8 or size number 6. So sometimes I want to help these small files to be more smooth inside the canal, and then I'm using the lubricant, but only to the moment when I'm reaching the full working length. After I reach the full working length, I'm completely finished the lubricant, and then I use only sodium hypochlorite during the whole shaping protocol. So we can see 6 orifices, and what was also interesting in this case, that palatal canals are merging. Now you can see there's a sodium hypo in palatal canal. I place a needle in the mesiopalatal and I connect it to the suction, and you can see it also disappears in the distopalatal. So they are merging, they are connected. I was also wondering if the 3 mesiobuccal canals, MB1, MB2 and MB3, are also connected. So I try to do exactly the same. Now I'm sucking the sodium hypo from MB3, and you can see the level is still the same on the MB2. Now I'm emptying the MB2, and MB1 is also fulfilled with sodium hypochlorite. So MB1, MB2 and MB3 are not connected, what was very interesting in this case. After shaping protocol, I'm doing the proper irrigation, and I got a second question: please describe your cleaning protocol. So my cleaning protocol, during the shaping protocol, I'm using only sodium hypochlorite. When I'm finished the shaping protocol and I'm sure what size and taper is my last one, and I'm not using the rotary or manual files anymore, I want to do the final irrigation protocol, because I'm stopping creating a fresh portion of smear layer on the root canal wall. That's why I'm now, when I'm finished with the in whole canals with the shaping protocol, I'm going to the cleaning protocol, to irrigation protocol. And my final irrigation protocol is to place some EDTA or citric acid for 1 minute, and then I'm activating it with ultrasonic files just to distribute it in the whole area of root canal system. Then I'm flushing it out, this citric acid, with a fresh portion of sodium hypochlorite, and then I place some fresh portion of the citric acid for another minute without any activation. During this minute, my assistant prepares me some gutta cones, and then I'm going to flush out the citric acid from the canal with copious amount of sodium hypochlorite. And during this sodium hypochlorite irrigation, I also activate this sodium hypochlorite with ultrasonics, 3 periods of 20 seconds of activation. Between these periods of activation, I'm reflushing the canal and I'm placing some fresh portion of the sodium hypochlorite. And after that, I'm fitting the cones. Sometimes I take an X-ray, like here on this slide. You can see this is the slide with master cones placed at the full working length, and these two that going together are palatal canals. And I'm fitting cones in sodium hypochlorite because it gives me lubrication. Because sometimes when we fit the master cone in dry canal, there is more resistance in dry canal than when we place a master cone with a sealer. And if we fill tack back in dry canal, sometimes it is not tack back anymore when we place some sealer. But when we fill tack back during fitting the master cone during the irrigation, for sure it will be the same with the master cone with the sealer. And as well, this sodium hypochlorite inside the canal gives me some, let's say, disinfection of the master cone. And after that, I'm just flushing the remains of the sodium hypochlorite with distillated water. And Carolina asked me, do you use any solution to dissolve canal material, gutta, Endosolve, if I'm doing retreatment? And if yes, I'm using some additional solvent, some orange gutta solvent. It's very nice to soft the gutta percha inside. And if we see under the microscope that the gutta percha is not the most part of the obturating material, the sealing paste is it is more the sealing paste, I use Endosolve. And here is the moment of this irrigation that I'm fitting the master cones. So you can see MB1, MB2 and MB3, and also this buckle were shaped to size 30 taper 4, and both palatals, mesiopalatal and distal palatal, were shaped to size 35, not 3004 and this 3504. And 2 angulation X-rays after the obturation. You can see that 2 palatal canals are merging, and even in 2 different angulations we cannot see the whole beauty of the and complex anatomy in MB root. I think only in cross section after the CBCT we will see 3 white spots of the cross section of the canal obturated with the gutta percha and sealer. And after I think 4 months, this patient come back to my office to do the retreatment of the next tooth, the tooth number 15. So I had an opportunity to check how this one looks like after 4 months. And you can see, you can compare. The left picture is direct post-op, the right picture is after 4 months. And the tooth was waiting still for the final reconstruction by I think post and crown. I don't know, because this patient was just a referred patient for endodontic treatment. So that's the end of this presentation. Let me switch into the camera mode. Now it's I'm bigger, and I'm want to answer your questions. The next question is: this system can be used in reciprocation and rotation. What movement do you prefer based on your experience? This system can be used, as you said, in a rotation movement, and not reciprocation movement, but anti-reciprocation movement. In classic reciprocation movement, it goes more left than right, because the file is designed like this. But in E3 Azure, it should go more right and less left. So it's not the classic reciprocal movement, but an anti-reciprocal movement. Or we got some special handpiece with OTR movement. It is combination of rotary movement and reciprocal movement. It depends on the resistance inside the canal. So from my experience, I more prefer to work with rotary movement. How many times do you use one file? What is your limit of using Azure? I'm keep Azure files. I'm keeping Azure files, each set separately in this paper plastic bag to sterilization, and I'm counting how many canals I already shaped with the set. And normally my limit is 15 canals. But if I see on the X-ray that will be a nice case for the presentation and the canals are extremely curved, I'm always taking fresh set, and then after this I count each curved canal as 2 normal ones. Okay, so I think that will be the end of the afternoon Endo Coffee. I hope you stay safe, stay at home. Tomorrow, the opportunity to have your attention will have Dr. Bartłomiej Karaś, a good friend of mine. So Bart, if you are watching this, my greetings. If not, I will try to catch you tomorrow on your webinar, and I'm sure it will be also delightful cases and pictures from under the microscope, because Bart is a great specialist. So see you tomorrow. If you had any questions, you can ask them under the webinar, and then we will try to answer them somehow. So thanks a lot for this time, and stay home, stay safe. Bye bye.